Thanks, Jane. Right, good afternoon and welcome to the Health and Wellbeing Board. It's great that everyone can join us. It's my first one as chair. So apologies if I'm a bit nervous on the first one. It's big kind of feat to get into. Firstly, do we have any apologies, Jane?
We have received 2 apologies, one from Simon Down and the other from Karen Kibblewhite.
Thank you. Item 2 is to confirm the recording of the meeting of the Health and Wellbeing Board held on the 5th of October. I did go through the minutes of the meeting, and I'd be looking for the following, I think, who were at the meeting, which was Councillor Wilby, Dr. Fox, Louise Platt, Mike Sandys, and Jenna Underwood and Mel Thwaite. So if for those of you who were at that meeting, who are members of the board, are you happy with that record? And could I ask for a proposer and a seconder, if that's okay, and just a nod that we're in agreement? Thank you. I think everyone, that seems to be everyone was happy with those. Was there any outstanding items or anything that people were concerned about in that needs picking up, do they think? By Dr. Underwood.
Thank you, Chair. In the minutes, I'm recorded as asking for the site of the transport plan, particularly in relation to any possibility for improved travel for access to healthcare. I haven't heard anything back. I'm just wondering if that was actioned or whether that's sort of fallen between the cracks with the departure of Councillor Walters and your arrival.
I think, well, Jane looks like she was coming in, but I was about to say I'm pretty sure that's on for our April meeting. I think that was what was referred to in the April meeting. I looked for Jane just for confirmation of that. Is that correct, Jane?
Bear with me, Chair. I will have a quick look for you for the work plan.
The last document, I think, and it was, we had changes to transport for accessing healthcare, including the new bus service improvement plan.
Correct. It's down on the agenda for the meeting in April.
Oh, brilliant. And is that what we were referring to from Dr. Underwood? Is that the one and the same thing?
Thank you.
Yes.
Brilliant. Was there any other comments or outstanding items from those minutes that members are concerned about? Just having a look around, there doesn't appear to be. Sorry, bear with me just 1 second because I've now taken myself to the end. So thirdly, we'll come to declarations of interest. Do we have any declarations of interest from any members? I'm not seeing any. Thank you. And number 4, do we have any petitions, deputations or questions, Jane?
None received, Chair.
Thank you. Do we have any questions submitted at short notice?
None received, Chair.
Thank you. And do we have any questions with notice from members?
None received, Chair.
And any notices of motion from members?
None received, Chair.
Thank you. So we'll move to the substantive items. And I think our first thing would be our step up to great mental health. And I think we're looking to colleagues John Edwards and Richard Morris to lead on this, if they would like to.
Yeah. Can everybody hear me okay?
We can, John.
Yeah, I have got a presentation. I've got some trepidation on trying to share it, but I'll try and do that if that's okay. Whilst I do that, I'm John Edwards. I'm Associate Director for Transformation, and I have been with colleagues from the CCG leading on this consultation process that we're going to walk our way through. can you see that screen? Is that coming across? That's
It
the way
is,
that
John, thank you, yes.
says. I've just tried to put it on the screen. If do flag if it doesn't work in some way. So I'll just walk you through it if that's okay, and then hopefully give time for questions. But we've been working on in the system looking at mental health services, which as true for most systems has been a challenge. Mental health services has been a range of problems and challenges within the system for some time. And we set off a good few years ago working with service users and carers and people from all sorts of agencies to try and look at what an improved set of services would look like. That culminated in a proposal of quite a wide range of changes that we put forward then into a formal consultation process, which was led by CCG colleagues, which Richard Morris is on the call as well. That then went through over the summer. We went through a wide range of engagement, which I'll talk us through in a minute a little bit. And then on the 14th of December, the CCG governing body, which is the natural state of the formal process, they approved a decision-making business case, which then agreed next the proposal to be put into place with changes from the consultation. Hopefully you connected with that consultation process, but I'll walk you through some of the features that we consulted on. So the proposed changes were organised into and presented into two lots really. One was changes to how people get supported when their needs are urgent and more planned services. The urgent had a wide range of specific changes, but all sort of coming together to be a much more joined up pathway. And one of the recognitions within the system was that services weren't working very well together, that people were falling between the gaps, and that there were people's needs not being met. So the overall thrust is to join up services, and that came across with all of the proposal actually, and to work very much more on individuals rather than trying to define people into criteria-based ways of allocating them to different services. There were some specific things that we consulted on. One was having a much clearer set of guidance and support that people can use that would be particularly electronically available. The introduction of the central access point, which we put in place actually during the height of the first wave of COVID in 2020. We consulted on making that permanent, and that's a direct line that people can ring without having to go through general practitioner or other routes to be able to get to speak to someone to support their mental health and be drawn into services if needed. We agreed to be putting in place crisis cafes, although the terminology didn't work for people. And so one of the recommendations that we agreed was to find a better terminology for it. But these are local offers in particularly in local areas. We consulted on having one for each neighbourhood, so that includes Rutland, that people could turn up to drop into and get supported when they're feeling particularly vulnerable and in some form of crisis, and get some local support, and then that really join up with wider professional crisis services as well. We talked about improving crisis services in general and expanding the use of triage car, which is a joint initiative with both police services and ambulance, so that if people are presented to emergency services, there's a much more tailored support for their mental health needs. The sustaining of the urgent care hub, another initiative that was put in place during COVID. This is in effect a place that's alternative to the emergency department, particularly where people don't need the sort of physical health offers that are in the emergency department. There's a mental health focused unit that's available for people. That's based on referral. It's not directly accessible, but emergency services, social care colleagues, other health workers can direct people to that particular service to get some urgent assessment and immediate support. One of the things that came out from the consultation in relation to that and the recommendation was where it is. At the moment, it's located at the Bradgate unit on the Glenfield Hospital site. One of the feedback that came through the consultation was whether that was the most appropriate place for it. And one of the recommendations that we're taking forward is doing an option appraisal of looking at whether that is the right site to continue that service by. So that will be undertaken over the next phase of the work. The introduction of Acute Liaison, so this is support around hospitals, and more joined up support with particularly vulnerable groups like people homeless, people that repetitively use services, and various others along. The planned services changes were about bringing together what currently is a lot of disparate services, lots of different services that have grown over time that don't always work brilliantly together, and joining up together to be much more joined up, organised geographically, and therefore more equipped to support people with the more local assets available to them in their local areas, but also avoiding people being bounced or being lost between services and waiting a long time for treatments. There were some specific proposals to improve, particularly the needs when people are diagnosed with personality disorder, and these are some of the individuals that have been waiting a very long time for treatment currently, or not able to get treatment, which is currently how that's been working. So the proposal is a much more defined set of what's like a tiered pathway, and a lot more of that joined up again, targeted to a more local area. It includes also strengthening support for people what's called perinatal, so people before birth and after, where that's a particularly recognised period where individuals do sometimes present with mental health needs, and that extra support could be really instrumental to improving their relationship with their child and also obviously their own health, and supporting other key things like psychosis and dementia as well. So they're the sort of mainstay. I recognise I've rushed through that. I'm welcome to take on questions, but I'm mindful of your time as well. A little bit about the consultation. We engaged with, in the end, we had over 6,500 people contribute to the consultation with their views, which we were really proud about. That was, in fact, more people engaged with this than they did the recent Acute reconfiguration, which is quite remarkable, we thought, because that wasn't certainly my expectation when we headed into this. And that's a testament in many ways to the work that the CCG colleagues have done in bringing together voluntary sector organisations to really get to a lot of local communities. And so we've had 40 voluntary sector organisations work with us, and they've really allowed us to get very close to lots of different communities across our geography. Of the people that contributed, I think 3% of them came from Rutland area, and I can go through a little bit later. There's some facts and figures around some of what particularly people in Rutland have said that may be particularly nuanced to this as well. The feedback that we received across the consultation was extremely positive, as this slide shows, with all of the questions that were posed being strongly agreed with. So that was a really positive. But there's lots of wider learning as well, and that came in the form of how much we needed to involve people in really designing the future state in local areas. There was really strong and powerful differences in local communities, how they were accessing services or why they didn't, why they trusted certain things and why they didn't. And the only way of really being able to implement the changes and the proposals well is to work very closely with those local communities to do so, including people that live in Rutland. And so that's a commitment that we made as part of the recommendations of the consultation, was to continue to work with our voluntary sector colleagues to find new ways of engaging with our local communities and making them supporters in co-designing all of the changes that we take from here on, to even greater degree than we have already. There also is a real emphasis of carers. It was an area that was pointed out as a weakness, I think, in our proposal, that we weren't strong enough about the support that would be made available for carers, and also their involvement in the individuals they're caring for's care, where often they were describing feeling excluded or poorly informed. And that was really taken heard as well. There's some further learning there I've just framed. So obviously there's a clear mandate to continue and to progress with the proposals, but caveated by doing so in a very considered way with our local population. There's quite a lot of feedback around digital, and this was true in Rutland as well. A strong positivity towards more digital offers, but not making it a mandatory way of accessing services. People wanted choice, and so a number of people were very positive towards having the option of digital, but did not want to be constrained to it, and that came across very clearly. Language was really notable. Having a central access point was very well received, but where people's first language wasn't English, and if they're trying to ring a number, particularly when in a period of distress, that was seen as a real barrier actually to getting that support. So there's a clear recommendation about how we can make this truly accessible to any language, or at least the main languages that are used in our collective area across the system. Choices I've referred to is really important for people, and being continuing to be focused on how we can adjust both the way our practitioners approach individuals and the way services are configured to being truly understanding of the cultures that they're trying to deliver to, in recognition that people felt that wasn't true now, or not true, or not working well enough. And a lot of people didn't know about services, and so there was a real emphasis about promoting and increasing awareness. So in summary, the next steps now is really about continuing to build on the work that we started with the voluntary sector through this consultation, and not just the voluntary sector, but the wider community groups as well, and involving them and putting some investment into them to help us to plan the next phase, which is obviously about trying to design it further and put it into practice. We've recognised we need to refresh the governance to have closer ties to things like the mental health wellbeing boards and the place-based agendas, as well as being fit for purpose to deliver a programme the size of this, which includes bringing together the outputs of consultation with some of the wider changes that we also are looking to make around mental health, which includes the strengthening of provision directly within local areas like primary care networks and other neighbourhood-based service areas. And we had intended to get a bit of a launch ready for middle of January. We're having to put that back a bit. The effect of Omicron on NHS at the moment, as I'm sure colleagues will be aware, is very significant, and it is creating a bit of difficulty in actually organising people together at the moment. So we're looking to try and have a kind of implementation launch, as it were, in February now, to try and give a bit of breather space to allow the immediate challenges to be attended to. But we'll obviously have to keep a watchful brief on that. I'll try and stop this presentation if I can. Let me see if I can do that. Is that stop sharing, or is that not?
We can still see your screen.
Let me see if I actually don't know how to stop sharing. If anyone's got technical gifts here.
I think if you press on the green screen at the green button
the bottom of your screen, it says share screen.
Well, bear with me. Apologies for the inconvenience. Oh, there we go. Right.
There we go.
That was
Brilliant.
a bit clumsy, wasn't it? But there we go. Just imagine that was smoother. That'd be better. I hope that's provided a reasonable overview of where we've got to with it. I don't know if you had any questions for myself or Richard, who's joined me from CCG as well.
I'll look, Councillor Wilby, and then we've got John Morley, and then Mike Sandys is coming in as well. So if we go Councillor Wilby, then John, then Mike.
Thanks very much, John. The words all look very good. Without being defeatist, how short are we of people to actually make it work?
It's challenging, I won't deny it. Workforce is has been a particular challenge for us over this course of this year. Some of this, or a lot of this, actually comes hand in glove with investment, and so we've got quite a considerable amount of money that's come in to support these changes and wider changes around mental health. I think it's fair to say we're getting more creative with developing new roles that are more appointable. There aren't unfortunately a magic fix, and so some of this will mean that, you know, it will build over the coming years, and some of this will effectively ramp up rather than have an immediate effect. But I think we should have hope. Nationally, there's a big focus on different solutions to the workforce as well, as this is a reality that's facing all systems. But it is a challenge. Yeah, it's an area that we're going to have to continue to attend to.
Thanks, John. John Morley.
Yeah, thanks for that, John. I absolutely welcome any developments in mental health, especially as, you know, going forward into place and what that specifically means for Rutland. Just a couple of questions, if I may, please. I was pleased to see about the expansion of the utilisation of the triage car, and I certainly think that's something that's really important in crisis intervention, and obviously getting the right treatment first. My questions are, how is that being expanded? As in, I mean, is it just a matter of more vehicles, which I suppose then comes back to David's point about the clinicians available to do it? And also, what actually triggers, or what is the referral route to that triage service, please?
So the expansion is in twofold, actually. So one is the original triage car was set up just with the police and didn't include ambulance services. So one of them is about it supporting both, which I think has been really welcomed. There's been trials of that over the course of different hot periods over the course of the last year or so. And to increase the cars to two and the hours range that they operate on as well. Staffing wise, at the moment, that seems to be manageable. In the grand scheme of things, it's a relatively small increase in staff compared to some of these other changes, so it's perhaps more deliverable. In terms of referral approach, I'm not fully conversant with all of it, sorry, John, but it will come through a couple of routes. So there's a direct way through the emergency services, so whether that's police and ambulance, and then a route internally through that. There's also a route through the central access point as well. And so if people work directly there and that's seen as the right solution, commonly it wouldn't be, but if it is, then there's a direct route there. So. But there may be others as well, and forgive me if I've not given you more.
That's perfect. Thanks, John.
Mike.
Yeah, thank you, Chair, and thanks for the presentation, John. I mean, subject to the previous sort of questions around availability of staff and dealing with COVID, is there anything that can be said about the implementation phase at the moment? I mean, obviously it starts in February. I just wondered if there was indicative dates, all being well, of when Rutland could expect to see some of the developments that were outlined in the first slide. I can't quite work out how long a timescale we're looking at.
I think that so I think we'll issue something over the course. We're working on trying to frame that time frame over the course of the month, and so be ready for February to have more detail. So whilst I recognise the premise of your question, I prefer to send you something more concrete then than give you a kind of not very clear answer. It would be worth noting, as I try to emphasize, that some of this is already in place. So some of that implementation is about improving what's there rather than necessarily putting it in place. Some of it, it's going to happen quite incrementally because some of it's workforce related, some of it's changing staff practice. We do have a lot of waiting times challenges to be navigating as we make the change. So I think that the detail will come. I welcome a further opportunity to come back to perhaps the Health and Wellbeing Board to go through that, and that might be a better way of doing it, so we can go through the detail. As I mentioned earlier, what I'm trying to work with Viv and others to make sure that we have it much more joined up, so it becomes a more regular reporting. It's not a one-off kind of occasion, that is sort of built into your place-based both plans and also in terms of reporting and outcome measurement as well. So hopefully over the course of the next couple of months we can get that really a lot clearer, and that you can get a much more up-to-date feed, so that Rutland really feels like it can track it and monitor it and inform it as it goes forward as well.
Thanks, John. And that was obviously, Viv was going to make that point as well. So as her hands come down, I was going to ask, it might be useful for our place-based plan. Obviously, we are due to have a special meeting on the 22nd of February. So I don't know whether that date is achievable at all, maybe for some of that further detail to come forward, so that we may start to see it developing and see it kind of coming through. It might be, if that is at all possible, that might be useful for the board, and then to come back with a much further report later on.
Yeah, I'd welcome it. Thank you.
Thanks, John. We'll go with Dr. Fox, and then, sorry, Councillor Waller, I know your hand is up and you're waiting patiently. We'll just go through the members of the board first, if that's okay. So, Dr. Fox.
Thank you. Just another question. I know staffing is always a challenge, but our patients, particularly the particular health inequality is the distance and the access to services and mental health is part of that. Where are we going to put the staff that we need in Rutland to meet this plan? Is that part of your plan? Have we got some sort of local premises? I know that the IAP service have been struggling to find somewhere to see people face to face. A lot of services are remote, but that makes it very difficult to integrate them into neighbourhood teams. So I just wondered how we envisage that working in terms of where we would have this mental health hub that we've been looking for.
So you know as well as I do, because we've had this conversation before. I think the reality is that's going to have to be part of this implementation process. There isn't a set place already earmarked to do that, so we're going to have to work that through. That's the importance of co-designing it locally, isn't it? So that it is the right places. It is using, if there are things that we can do more flexibly with what we've got, we need to be maximising it, don't we? But otherwise, we're going to have to find solutions. We're seeing that, as you know, Hilary, through the other parts of this, which is neighbourhoods development as well, where we're expecting to have more staff, aren't we? And we do need to find these kind of solutions. And I think also particular to Rutland, which is a slightly tangential point, but we've also got to be really considerate about the neighbouring offers, don't we? And the relationship with those as well. Particular, well, not necessarily unique to Rutland, but very notable in Rutland. about the close proximity to Lincolnshire and Cambridgeshire and the relationship with those services. So yes, I think that's work that we're going to have to work through, but it can only be worked through together. I don't think it'd be right for us to find an isolated solution, because that would probably not interconnect with the other things going on with Rutland. So that's got to be on the agenda. And I guess we have got some resources to support that, so that's useful, but we have to see how far we can go with it, I think.
Thanks, Tom. Is that okay, Hilary? Yeah. I was going to ask one question myself, and then I'm coming straight to Councillor Waller. And you kind of touched on it, and I was just wondering around the perinatal services and how that specifically links up with our mums who choose to give birth outside of LLR area, and how that is going to be looked and integrating in, certainly around the east of our county.
Yeah, I think the reality is that there is complexity there, and that's something we're going to have to work our way through, because there are perinatal offers also in those areas as well. And there is a little bit of navigation to be done depending on where their GP is still. And so that's not always the best proxy of whether that's the right type of service to support them. The moment they wouldn't be excluded from that perinatal service, and the perinatal service have it as part of their duty to work with those other maternity services. But I think that's an area that we're going to have to make sure is as strong as it needs to be going forward, because recognise that that's part of that challenge that I was referring to earlier, about making sure that it really is as joined up as it can be, not just within LLR but also outside of it, which I think has come across in a number of instances around this consultation.
Thank you. I know Fiona's hand up went up at that point. I don't know whether I think it's gone down. So if I'll hand over to Councillor Waller. Oh, Fiona.
No, that's okay. I was just going to come in on that point that John was raising. I think it's really important that we co-produce the implementation with colleagues locally, and to absolutely iron out some of these current seemingly tricky issues, and how we can make the ideal service delivery locally. Thank you.
Thank you. Councillor Waller.
Thank you very much, Chairman. I've got a couple of questions based on your presentation, John. It seemed to me that your response rate that you thought was awfully good, and it was in total, I've no doubts, but only 3% of it was from Rutland. Well, is that because we're only 3% of the population? You didn't give us a context for that, and that sounded to me quite low. I mean, I may be wrong. And equally linked to that, and it's essentially the same question, when you were involved with the voluntary and community sector, how much of that was in Rutland as well? Because I do feel, and I realise from listening to colleagues that they also feel, that we're a little bit out on a limb over here. And whilst many of us access different services outside of LLR, we don't necessarily want to access all our services outside of LLR. And picking up the chairman's point, you know, I might go and have my baby. Well, I won't have babies now at my age, but I might have got to have my baby in Peterborough. Mm-hmm. If I had any mental health problems afterwards, I wouldn't want to keep going trailing over to Peterborough for them. You know, it's because of the geography, I guess. But can you give us some sort of Rutland context, please?
Yeah, I'll draw on my colleague Richard on some of the detail of the consultation bit, if that's okay. But just to I don't know if I was clear when I was saying before. Certainly, if you were choosing to have mental health service support from the Leicester Rutland offer, you would have that. You wouldn't be forced into using Peterborough if you just had a baby there. So that wouldn't be something that happened. But I think I was just referring to the interface between the services that are happening in Peterborough and the ones in Leicester. We definitely need to attend to make sure that really does work well. And sometimes it's a breakdown of communication or sharing information or coordination that doesn't work very well. So that was the point I was making around that one. really in particular, but if Richard doesn't mind picking up the question specifically about the Rutland engagement through the consultation.
Yeah, of course, no problem, John. And thanks for the question, Councillor Waller. So kind of going into the consultation, what we're aiming for is to try and ensure that the response rate is as broadly demographically representative as it can be. So ostensibly what we're kind of looking for is around 3.5% of the responses to be from Rutland, as 3.5% of the population of LLR are Rutlanders. So in terms of the number of people that responded to the survey, we're ever so slightly below that, just over 3% compared to that 3.5%. What I would say though is two things really. So first of all, that data is based on the number of people who actually provide demographic profiling information when they complete the survey, which many people don't. So it's only based on those people that do provide that information. I think the second bit, which is probably in many ways perhaps more important, is the bit which you were alluding to, Councillor Waller, which is around the partnership work with the voluntary and community sectors, some of which was absolutely specific to Rutland and the people of Rutland. So working with some of those voluntary and community sector organisations, we had 7 specific engagement events, some of which were online, some of which were face-to-face, which took place in Rutland for Rutlanders, and particularly sought to engage with people who maybe don't typically kind of take part in these kind of processes. So for example, we had specific events that took place with veterans that live in the county, as well as events that took place with carers, and also representatives from the farming community. So I think overall, I think kind of my view is that whilst the number of people who took part in the survey was probably just below, I think when we factor in that additional activity with the VCS, I think we've got a pretty good representation. And the key thing for me is then when we start to look at what did the people of Rutland tell us compared to the wider population of Leicester and Leicestershire, are there any noticeable differences? And broadly speaking, there wasn't. People were just as supportive from Rutland as they were from either Leicester City or Leicestershire County, with some of those nuances that John was talking to in his presentation at the start around, you know, wanting to see that care delivered as close to home in Rutland as is possible.
Thank you. May I come back one thing on that?
Of course, Councillor.
Thank you. I think our colleagues in health who don't live in Rutland need to be aware that we are in some ways more remote than you might think. And Oakham as a place to get to if you live in the east of the county is well nigh impossible, which is one of the reasons people use Peterborough, because actually there's a bus to Peterborough. There isn't a bus to Oakham from where I live or any of the villages along the road, the main road that runs through mine. And you might put a service in Oakham, but it isn't necessarily accessible. And I'd like that reinforced, because I do know that people from the Uppingham area were making that point very strongly some while ago. I don't represent Uppingham, but I am aware that it's a concern for them. Thank you.
Thank you, Councillor Waller. Was there any other questions from the board at all? No. I think it would be really useful if it would be possible, John and Richard, to have some of that more detailed stuff to do that for a meeting. Really helpful, just so that we can, so that Rutland residents can see the kind of vision and what they might expect to start seeing on the ground. Which I think it would be really useful, and then you'd be very welcome to come back and present further findings and develop how we're looking, so we can co-produce this.
That'd be wonderful. If there is something that you want for the 22nd, if someone could make contact with me about the details of that, then that'd be helpful, and then I could try and make sure I support that.
Very much so. So Jane, if you can action that for me, and we'll catch up, John, and look at how we can best bring forward what would kind of help just to feed into that place-based plan, so that we can start to see how it will co-produce and how we can all work together, and how we can bring services closer as well, because that would be that's kind of, I think, one of the #1 things. Thank you very much for the presentation. both you and Richard, I'm sure you are more than busy this afternoon. So if you did want to, you're more than welcome, obviously, to stay for the rest of the meeting. But I appreciate you've both got very busy schedules. So if you want to leave us, we'll say goodbye and we'll see you again next month.
Thank you.
Thank you.
Thank you. So next we move over to the pharmaceutical needs assessment, and I think Mike's leading on this. So if I can hand over to you, Mike.
Yeah, thank you, Chair. Apologies from Kajal, who was due to present, but unfortunately is off at the moment with a family bereavement. I'll take the paper as read. So just do a very brief summary. Viv, if there's anything particularly stunning that I forget, do shout out at the end. So as it says, purpose of this report is to highlight the responsibility of the Health and Wellbeing Board to produce a pharmaceutical needs assessment. People who've been on the board for some time will know it's not the first of these that we've done. The Health and Wellbeing Board needs to produce a pharmaceutical needs assessment, henceforth known as a P&A, on a 3-yearly cycle. This one should actually have been completed for the 1st of October last year, but nationally the deadline to produce these reports was eased by a year because of COVID. So we do need to produce it as a Health and Wellbeing Board and publish it by the 1st of October 2022. In terms of the purpose, that is largely laid out in paragraph 2.2. It sets out the provision of pharmaceutical services that are currently available within Rutland and assesses the need for pharmaceutical services in the future. That's then used by the Commissioner, NHS England, but I think the CCG has been given delegated authority in the future to inform their planning of pharmaceutical services, notably around kind of permitting a new pharmacy or a dispensing doctor to provide a new pharmacy within Rutland. Then what have we got out of the paper? Moves on to set out the consultation phase, which is kind of 2 bits. There's the intelligence gathering phase, which is set out in sort of paragraphs 3.1 onwards, including a couple of surveys, one to ask current service users of their views on current provision, and the second to gather data on the scope of the services that are provided, as it says in 3.1, opening times, etc. Then we need to do, as a Health and Wellbeing Board, a 60-day statutory consultation period on a draft of the P&A itself. So that gives a number of organisations detailed in 3.2 the opportunity to comment on the content of it. The express and explicit content set out in Appendix B. And then the last thing to cover is just our kind of governance. So the good news is it's not the Health and Wellbeing Board that actually writes the P&A. Responsibility is delegated to, well, Kajal and colleagues within the analysis team of Leicestershire that's also providing that service for Rutland, with a reference group, a steering group, which I chair, which actually works across LLR, because it's important that the 3 Health and Wellbeing Boards in LLR produce their own statutory document, but obviously it makes sense to align them as best we can so we get a content and a layout similar, which obviously makes it more useful to NHS England and NHS colleagues. And that's set out there in paragraph 7. So that probably is a quick run through the paper, and I think the recommendations are to note the contents of the report and the establishment of the steering group. So I'll pause there. Viv, anything I've missed? If not, I'll pick up any questions.
Where's Councillor Harvey disappeared to?
Yeah, she's disappeared, hasn't she? In her absence, while she rejoins us, shall I take questions then? I don't know who was first. Was it you first, Janet, and then Hilary? Yes. Councillor Harvey's back.
Apologies, everyone. Zoom threw me out right at the beginning of your presentation, Mike. I think as I came back in, Dr. Underwood and Dr. Fox had their hands up. We'll go to Dr. Underwood first, and then through to Dr. Fox.
Thank you, Chair. I'd just like to clarify something, if I might, Mike, please. As the paper reads, it sounds as if Health Watch Leicester and Leicestershire and Health Watch Rutland are sort of one organisation. We're not, we're two separate organisations, and Health Watch Rutland was not actually invited to be part of the steering group, the reference group. And also the person that actually represented Health Watch Leicester and Leicestershire no longer works for Health Watch.
Okay, thank you, Janet. Sorry, I hadn't picked that one up. I will let Casual know, and we'll make certain that Health Watch Rutland get an invitation to the steering group, because you're quite right on that one. And I'll let them know about the change in personnel too.
Thank you.
Dr. Fox.
Thank you. Welcome the inclusion of the dispensing practices as part of this review. Probably about 30 to 40% of people who live in Rutland use their practice for obtaining medication, and obviously for the dispensing quality schemes and all the other things that go with that. So I suppose I'm asking that that be considered as part of this review in its entirety, not just where those practices are that are dispensing, but actually all the different services that they are providing in terms of medication reviews and dispensing quality reviews, which I know that they are doing. Thank you.
Yeah. Okay.
And I do have a question. Forgive me, Mike, if you answered this. Obviously, I kind of, because I missed the whole presentation, rather than going back, I'll just ask you to whether to answer. The one thing I picked up on here was medication reviews, and obviously due to COVID, we know in some circumstances there is an issue around them, and obviously COVID isn't going away anywhere, and we know our colleagues within primary care are completely snowed under. Certainly, I was wondering whether there was would there be any way of looking at whether we could come up with a novel way of maybe getting some of these medication reviews kind of done in looking at the shorter term to take some pressure off our primary care, but to ensure that all our residents have had timely reviews and they are coming back in line, knowing that we're 2 years into a pandemic that with Omicron, as we've just recently seen, looks at the moment like it's going nowhere fast. So again, you might have touched on medication reviews in your bit that I missed, so apologies if you did.
No, it's a good question, in as much as a needs assessment, it sets out what's currently provided and where. It can make recommendations, which notably are normally sort of geared towards exactly where services are provided. And last time around, we started touching on the role of online pharmacies, which again, I think is more of an explicit thing we need to put in this time around. I'm umming and erring a bit because the balance is, it's not the role of a needs assessment to say, actually, here's a good idea. You need to think about pushing the boundaries around how you do your meds review, because that would come through kind of primary care strategy. But certainly within the steering group, I can have that conversation, because you're kind of missing a trick if maybe the needs assessment doesn't highlight, actually in the current circumstances, this is what should be provided. But actually, it's almost a way of bringing out the wording, which then means that the appropriate group can take forward the thinking about how we might do things differently, as opposed to saying, do they need to do things differently, if you see what I mean. It's not supposed to be torturous, but I'm trying to sort of get in my own mind, what's the role of a P&A and the P&A steering group versus what's the role of design groups around condition management or primary care. I'm sort of looking at Hilary thinking, sorry to pick on you, Hilary, I'm just trying to think what would be the best way of teeing up that conversation.
Did you want me to come back on that?
Yeah, well, if you got any thoughts, about, because it's a reasonable point, isn't it? But it's more a conversation that needs to be done through primary care, which we then prompt.
Yeah, certainly the role of I suppose there's two aspects to this. One is the prescribing and the other is the dispensing, and the pharmaceutical needs assessment is more geared towards the dispensing. The community pharmacies and the dispensing practices all do dispensing reviews. So that's about how people know how to take their medication effectively and so forth. But on top of that, I think Councillor Harvey might be referring to the more prescribing reviews, which will be the job of the pharmacists within the GP practices. And certainly we've taken on a lot of extra pharmacists this year to do those medication reviews. We know we have a backlog, and we know the size of the backlog and what our plans are to tackle it. But whether it forms part of the actual P&A, it will be a different way of approaching it.
So I now I've set that thought into Ponderland. Shall we ponder and just maybe come back and once we've pondered.
Sure.
Rather than I just thought it might be another way to take some of the to help take some of the flat, rather than just we always seem to be looking at primary care going you do, but they only have a set capacity and they're full at the moment. And actually, if we could maybe think of some novel ideas to help take some of that flack off, it would be really useful, or some different ways of doing it. I just thought, but for we've sat here for a couple of years, I think, saying we'll catch up when COVID, we'll catch up, COVID will catch up, but it seems to me we're getting to the point where actually we need to start thinking outside the box with some novel ways at the moment, because COVID doesn't seem to be going. It's sticking around, not like a quick cold anyway, is it? So that's my concern, that it's we seem to be kind of up in peaking and troughing all the time, don't we? And we're kind of lurching into from one COVID crisis to the next, and meanwhile things are backing up and backing up. Does anyone else have anything further on the PCN? Pharmaceutical needs, P&A. Sorry, thank you. And we were noting, weren't we? And we were noting it and agreeing to receive further updates, weren't we?
Yeah, sorry, that was the second one, isn't it? Yeah, just to receive reports on progress, including the draft, before it then goes out for consultation, I think.
Yeah, brilliant. So we're all happy with that. Excellent.
Cool.
Brilliant. Right, next is my statement. So when we were we had a little discussion, we thought it might be useful for me to prepare a statement each meeting to give a local thing. So I will, it will be attached to the minutes and I shall read it out for you. So the Health and Wellbeing Board is a key meeting point and driver for health and wellbeing in Rutland. And I'm pleased to take up the chair of this board as part of my new role as Rutland County Council portfolio holder for health, wellbeing and adult care. I take over from Councillor Walters, who I'm sure we would all like to thank for his long-standing commitment and services to the board. As the new chair of the Health and Wellbeing Board, I would like to introduce an element to our board meetings, which is the chair's update, bringing together regular current information and a number of key themes relevant to the business of the board. Updates will initially be focused on the pandemic as a critical aspect of our work together, and the update will evolve over time, and I'd welcome feedback on what updates would be most valued by health and wellbeing members and the wider audience. So the first thing is a coronavirus update. In line with the national picture resulting from the high transmissibility of the Omicron variant, rates of COVID infection have continued to rise rapidly in Rutland since before the new year. The 7-day rate of COVID-19 cases in Rutland up to the 4th of January 2022 was 1,571 per 100,000 population, a rise of over 30% over the previous week. This figure marks the highest incidence to date in Rutland, where both the rate and the rate of increase were lower than the English average and the Leicestershire average. Incidence in the over 60s is rising steeply, but remains proportionately lower than the national and Leicestershire average at this stage. If similar to the trajectory in the London area, and by continuing the measures in place, the local wave may hopefully peak and start to level off around the end of January. As a result of the pandemic, the LLR health and care system remains under significant pressure. LLR and local committees and cells coordinating pandemic responses have been stood up once more. Acute services are facing a combination of increased hospitalisations because of COVID and or with COVID, combined with reduced staffing levels due to COVID infection or self-isolation and recruitment challenges. Some key organisations are 15 to 20% down on usual staffing levels. A national reduction to the duration of self-isolation from 10 to 7 days is likely to be of some help in mitigating this. Meantime, some planned hospital appointments are being postponed, and swift discharge from hospital remains a key aspect of maximising bed capacity. Social care providers are also under pressure locally as elsewhere, with staffing challenges in home care in particular having the potential to impact on the speed of some hospital discharge. Within RCC, day opportunities for adults with learning disabilities have not yet been fully reopened for the new year to allow staff to be redeployed in our in-house home care team, MyCare, to support the care at home needed by some for timely discharge. Dashboards indicate currently that Rutland care homes have either no or very low incidence of COVID-19, and there are no current outbreaks, although they are facing some ongoing staff challenges. Vaccination rates are very high. 98% of residents are double vaccinated, 95% of them boosted, and with 89% having had their flu vaccination. For staff in care homes, everyone eligible is double vaccinated, as required now by law, with a booster rate of 67%. Flu vaccination rates are rather lower at 48%. Supplies of PPE are also healthy. The ability for people to test whether they are COVID positive, and if so, go into isolation, is important to slowing down disease transmission. This is especially vital as the Omicron variant is sharply more transmissible than previous COVID-19 variants. A reproduction number of below 1 is required for the disease to start to reduce in the community. The R number was estimated on the 7th of January to be 1.2 to 1.5 in the Midlands and in England as a whole, i.e. for every 10 people infected will lead to a total of 12 to 15 further people being infected. The availability of lateral flow tests for people with no COVID symptoms to check they are COVID-free before attending a workplace appointment or event, and of PCR kits or appointments, mainly to diagnose they were asymptomatic, has been a widespread issue nationally over the festive period, with some breaks in supply or appointment shortages owing to extreme demand. National adjustments to COVID regulations are hoped to have a stabilising impact on PCR test availability by removing the need for asymptomatic people who have tested positive on a lateral flow test to confirm with a PCR test. Some pharmacies are supplied directly to provide lateral flow kits, and some of these have experienced recent delays to replenishment. In addition, RCC's community care services are continuing to distribute high numbers of test kits locally via 2 routes. The first is a van operating pop-ups on variable number of days per month, setting up at places such as Rutland Water, supermarkets, etc. Distribution via 60 community collect venues or groups across Rutland, included in many of the smaller villages. Channels include libraries, villages and charity shops, village halls, sports centres, good neighbourhood schemes, churches and community groups. This is particularly targeting people who may be disproportionately impacted by COVID-19, or those who find it more difficult to obtain test kits. The supply of kits to the council was not smooth over the festive period, with a late delivery just before Christmas, which was distributed at speed on Christmas Eve with the help of county councillors, who got 61,520 kits out to the community in 24 hours. New stock was delayed in the new year, but venues are now being restocked to sustain supplies. For those who are unable to order their test kits online, information is now being given out with council distributed kits, which encourages the public to order their subsequent kits, if they're able to do so, directly from the government website. An extensive vaccination program continues, with a focus at this stage on boosters for those double vaccinated and vaccinating the younger population who have become eligible more recently. The latest data to the 8th of January indicates that in Rutland, 88.6% of the population has had 1 dose of vaccine, 83.3% 2 doses, and 67.5% also the booster or 3rd dose. with higher booster rates indicated in the east of the county. Inaccurate public information was identified before Christmas relating to local booster appointment availability, and this has now been resolved, making it clearer that booster appointments are straightforwardly available within Rutland. I'd like to thank colleagues personally for that swift way that those communications were put back out, and the help certainly from the primary care network in helping to get that information out quickly. Responding to wider pressures, further grant funding is coming into place, administered by the council, including to support the hospitality and leisure sector in light of the Omicron wave. The council will issue communications about how this can be applied for as soon as arrangements are in place. Meantime, various voluntary sector partners are highlighting the increasing likelihood of financial hardship and dependency on support services in our communities as a result of a range of factors, including rising fuel prices, inflation, and the impacts of the pandemic, for example, on household income. Support remains available via the council for individuals who may be facing practical or financial challenges in self-isolating, and from the Council or Citizens Advice Rutland for those who require advice and assistance around financial hardship more generally. Earlier this afternoon, just before we came online, we did actually also receive an email from EMAS to inform us that the Ministry of Defence have made arrangements for 60 military personnel to work alongside our EMAS colleagues, responding to patients requiring interfacility transport who have already been seen as a healthcare professional. At this stage, they're not planning to use military colleagues as part of the 999 ambulance call response. I shall forward that email to councillors and making sure that it is attached as well. As a final note, I'd like to commend the continued hard work and dedication of frontline workers in Rutland and wider in healthcare and other key sectors during a very challenging festive period and beyond. I'd also like to thank the population of Rutland for their continuing commitment to following pandemic advice to help to stem the spread of COVID-19 and reduce the threat of vital services being overwhelmed. As we move into 2022, I hope that we'll soon be able to resume fuller and safer lives. Thank you. As I said, that's our first update. If members of the board can think of anything useful further, or if you wanted to update me or to have added anything included in an update before each meeting, then please do contact us, because we feel it would be really useful. I do also intend to, that update will be included with the minutes, but I also intend to send it out to all councillors, and I'm also happy to send it out to colleagues if they so wish, if they wanted to publish it too. I think it would be really useful if we can start moving that forward, because it also highlights the work that us as a board and as working together are doing. Thank you. So item 11 is enhanced public health offer at Rutland County Council. And I think we're over to Vic for this.
Thank you, Councillor Harvey. Yep, thank you, everybody. Just thought I'd update everybody today on the sort of refreshed approach to public health in Rutland as a place and as through Rutland as County Council as well. And this is following discussions that there's been discussions between Leicestershire Public Health Team and Rutland County Council, because many of you will know that as Mike is here on the call as well, that Leicestershire County Council provides a public health support offer for Rutland, and it's basically we're just updating partners on what that new offer will look like and what opportunities that will bring. So if we look through the paper in terms of sort of what that new offer will look like, obviously we've still got Mike as the Director of Public Health. There's additional consultant capacity in myself now for a couple of days a week. And we've got two strategic leads that will be working specifically on public health areas of work for Rutland. On top of that, we have public health analyst support, and we're also very fortunate to have additional support as Sandra on the call today, who has moved to become the Health and Wellbeing Integration Lead, which we're really pleased to have. So basically what we're looking at having is sort of a mini public health team specifically for Rutland, which will really hope to drive some of the public health priorities and some of the opportunities around health and wellbeing for Rutland as a place and Rutland as a local authority. And so what the paper talks about in terms of area 3 is just really about sort of the background around public health. So many of you will be aware that public health is defined as the science and art of promoting and protecting health and well-being through preventing illness and prolonging life through that organised efforts of society. And I think there's something very much around public health about it having a scientific background and sort of a technical background, but then also having an area around the art of public health and that influencing and how we can support those agendas. Having an understanding of both health and local authorities is quite a useful area that we can support and drive agendas through. And what I talk about in 3.2 is the different domains of public health. So many of you will be aware of the 4 different domains, and I'll come on to those in a minute, around improving health through the wider determinants of health, health improvement, health protection, and also that healthcare public health offer. And the ways in which public health can support that is we quite often talk about a framework in terms of a leader, partner, and an advocate. So public health can lead specific areas through direct commissioning and areas through the public health grant. So we have that defined public health grant for Rutland, and we do buy-in and commission services to improve health and wellbeing through that. There's also a lot of opportunities to work through as a partner, really driving that collaborative change and really driving some of the opportunities that we've got, that we've talked about a lot in this meeting already around Rutland as a place, the work with the wider integrated care system, and also that system leadership. The other area that public health can support around is around that advocate role and how we really work with our local residents and our local population to support them to have informed choices around how they would like to improve their health and well-being. Now, some of that might be through communication, social marketing campaigns, and areas around that. But then other areas will be working around how we really build those strong and resilient communities in Rutland and use those asset-based approaches to embed some of that methodology. So I won't talk through the emerging themes because many of you will be aware of those, because these are the areas that have been highlighted in the joint health and wellbeing strategy. And many of you will be aware that that is currently out for consultation. That consultation has been extended to, I think, the 16th of January now. Yep, Sandra's nodding, thank you. So we really are keen to hear your views and thoughts around what those priorities are and really think around what we want to shape in terms of driving the priorities for Rutland. But if I move on to sort of Appendix A in the document, here we've got the different domains of public health highlighted. And this just gives you a bit of a flavour in terms of some of the things that we're looking to, I suppose, try and embed new areas of work in Rutland that we may not have particularly highlighted before. So one of the key areas that we're really keen to do is really work with partners around the wider determinants of health. So many of you will be aware of the Dahlgren and Whitehead model around the social determinants of health, and an understanding that there's so much more in terms of some of the wider determinants of health. So we might be thinking around education, employment, housing, climate change, the societies and social capital that we have around us, that can really influence and have a much greater impact on our health and well-being than, say, just access to health services. So we're really keen to work with colleagues, particularly in the Places Directorate within Rutland County Council, to think around how we can embed a health and equity lens through all of the work of the local authority. We are also building those relationships with the other directors. I can see John and Dawn on the call as well, in terms of how we can really strengthen the work that we do with public health and how we can add value to what the work that is already going on. So the other area that I'd just like to highlight in domain 2 around health improvement is around the making of a contact count. This is an area that has come up quite a lot in terms of the joint health and wellbeing strategy. And I think this really is about embedding a prevention approach across all partners in Rutland. So really utilising those opportunities where we have individuals in front of us, and how we can think around some of those wider determinants of health, and also how we can support people to make the choices that they want around preventing risk factors and disease within their own health and well-being. We've talked, Councillor Harvey's covered quite a lot in terms of some of the health protection remit, and a lot of that work is linking in with the UK HSA and the CCG around the COVID pandemic response, with obviously Mike leading a lot of that work for Rutland specifically. And then the other area that I'd really like to work more on is really understanding the healthcare public health offer and how we can embed a population health management approach. We're really fortunate in Rutland that we've got one PCN aligned with the geographical boundary, and there's some really great integration work that's already happening, and it's how we can build on that and really work with the PCN really closely moving forward in the joint health and wellbeing strategy around some of their priorities. So really what I just wanted to highlight is there's lots of opportunities around. We've got new members of staff starting, which will mean that we can get into some of the detail of some of the issues that that Rutlanders have. And just the recommendations for the board really were to note the content of the paper and the revised public health offer, and really provide any recommendations for priority public health areas that you would like to see us focus on over the next 12 months. So I will leave there and open to questions. Thank you.
Thank you. Do we have any questions from members? Dr. Underwood.
Yes, thank you, Chair. I found this paper really, really interesting, so thank you, Viv. One of the things that Healthwatch Rutland has become ever more aware of is that the public want to be taken on the journey with place-led planning. And I think that came out with John Edwards with mental health care. The public want to be involved. I think there's an opportunity here to have the public involved in the public health offer as well, if that's okay with you.
Am I okay to respond to that, Councillor?
Of course, please do.
Thank you. Yeah, I mean, we'd be really keen to have a conversation with you, Dr. Underwood, about how we do that. One of the things that I think we're really keen to do is really think around how we evolve the work of the Health and Wellbeing Board and the conversation between the Health and Wellbeing Board through the Joint Health and Wellbeing Strategy with our local population. So as we talked about, we've got the consultation that's open at the moment, but that really is about starting the conversation. And I know that we are looking at how we embed a communication and engagement strategy as part of that. And public health is going to be absolutely integral in terms of how we can support the delivery of that joint health and wellbeing strategy and part of that. So happy to have a conversation offline about that around the public health office specifically, but be assured that there's a lot of work that's going to be done around the board more generally around.
Thanks. I think we have Mike and then Dr. Fox.
Yeah, thank you, Chair. Not so much a question, just a comment really to echo Viv's response then and Janet's question. I mean, I think it's important for us all, and certainly from my perspective, it's not just a question of saying, here is a revised public health offer, please help yourself to it. It forms part of one of the building blocks about boosting Rutland. So the Health and Wellbeing Board development, the Health and Wellbeing Strategy, the integrated care developments within Rutland are all kind of the four quadrants, if you like, of an overall picture, and self-evident, but hopefully worthwhile just saying, because I wouldn't want people to just think we're offering to do more without understanding where it fits in the bigger picture, if you like.
Thanks, Mike. Dr. Fox.
Just on the public health outcomes framework, Rutland looks pretty good on a lot of the parameters, and the broad brush frameworks like this tend to miss out on the small numbers, and because we're small, we miss the very small numbers. So if we take something like breast screening, for example, we do very well as a whole in Rutland on breast screening rates. However, unless you can access the breast screening unit, which comes in once every 3 years, so if you happen to be 50 just at the wrong time, then your breast screening will be delayed and you'll have a 48-mile round trip to Glenfield. And it's likely to be that a small number of people for whom that is impossible, who are disadvantaged. And there'll be plenty of other instances like that that will be completely missed in terms of public health data at the macro level. So I think what I would like to see from the enhanced public health offer is that we really delve into the small communities and the small numbers, and we make sure that we deal with health inequality on that micro level and not just on a broad brush that Rutland's doing very well.
Thanks. Viv, do you want to come back on that and then over to Dawn?
Yes, thank you, Councillor Harvey. I absolutely agree with what Dr. Fox is saying there. And I think one of the priorities that we've got in the Joint Health and Wellbeing Strategy is around health inequalities in Rutland. And I think when you think of health inequalities from a wider LLR area, people tend to go for geographical areas, and actually for Rutland, I think that's going to be very different. It might be around specific communities, around specific groups, and it is going to be very much at that macro level, Dr. Fox. So we're one of the key areas that we've got Mitch, who started only this week, is I want him to do a needs assessment about really understanding what the inequalities are in Rutland. So we will absolutely make sure that you're engaged in that, and other partners as they would like to be, so that we can make sure that we can utilise your local knowledge to really unpick some of that. And some of it might take a little bit of time to work out, and that's fine. And I think we need to be aware of that, but acknowledging that, you know, the traditional data sets, we get a lot of data suppressed because of the small numbers. So we might have to think about it in a different way to really understand the picture.
Thanks, Viv. Dr. Fox, do you want to come back, or is that okay?
Oh, that's great, thank you.
Thank you. Dawn.
Thank you, Chair. It was really just a couple of comments, really. Generally, I mean, I really welcome this paper and the discussions, certainly that Viv and I have been having in relation to public health offer in Rutland. And it was really just to reflect back to the board the impact that this is already having, particularly in terms of children's services. I think children's services are far better engaged than perhaps have been previously, and the impact particularly around thinking about those wider determinants of health and addressing health inequalities, starting to see that particularly in terms of the recommissioning of our 0 to 19 service, and particularly those non-mandatory elements, which will be coming back through this board. But I think it's been really important to kind of have that better engagement, and certainly very much focused on what the Rutland specific need is, rather than being kind of lumped in to a Leicestershire and Rutland offer. It's very much kind of the focus now being on what are the needs in Rutland, and we're starting to see the benefits of that from a children's point of view.
Thank you, Dawn. I had just a couple of comments on the paper, which it's a really good paper. The one thing that was glaringly missing, and Councillor Waller won't be surprised to hear me raise this, there was no mention of dental care, certainly in our under fives. And as we heard at Joint Health Scrutiny, dental decay in under fives in parts of Rutland is running at 40%. I do think that we need to certainly not let that slip, and I think it does need a mention, because there is an issue, and it's an ongoing issue. We know historically it's not getting any better, so I think we need to maybe look at adding that in if we can. And then my other thing was, and it's around in some ways kind of a bit of language as opposed to, so our next, obviously we're coming on to the new armed forces legislation next. I know we do discuss our military populations. We don't actually specifically mention our veterans. And obviously we know that 20% of Rutland population has a connection to the military. And I think it's really important that we kind of include them as a whole, because they are a big proportion of our people. And then my only other comment was on the last page, so it's my page 32. Sorry, it's under domain 1, the last header, improving the wider determinants of health. we say consideration may be needed for climate change, air quality and road safety ECC. I would argue that we need to change that to must include, because obviously as a council and as members, we did pass a motion on climate, and therefore we do need to, I think we need to include that from the beginning so that it's intrinsic throughout everything. So rather than a may, I think we need a need, if that's okay. But that was just my two little points there. Viv, do you want to come?
Yeah, thanks. Happy to make those amendments. That's not a problem at all. Just to reassure you, in terms of the dental decay in under fives, that has come up as a priority in the joint health and wellbeing strategy. So that will very clearly be one of the priorities in there. So we will ensure that that works moving forward. And also just wanted to highlight that there is some work. I know Advate in the CCG is doing some work around really understanding some of the needs around the veteran and military populations more globally across LLR. And what we will be doing is getting Mitch to support some work with him to understand what that means for Rutland. Because I think because Rutland's got such a strong, got such a significant proportion of the population within those groups, it would be really good for Rutland to lead some of that work around really understanding what those health needs are. So that will also become quite a key theme through the joint health and wellbeing strategy, and no problem, we can certainly add something in around climate change. That's
Thank you. Did anyone else have anything to add? Are we happy? Then we are we're noting the content, and then we're providing recommendations for priority public health areas to focus on over the next year. Are we happy that we've achieved that? I think so. Thank you. And next we're moving, I think we're moving on to Better Care Fund, and Sandra, I'm afraid you're up for this one. Thank you.
Thank you very much. So I'll keep this one short. Now, we find ourselves once again in a bit of an Alice in Wonderland situation with our Better Care Fund programme, where we're asked to go through an approval process for a programme which has practically all been delivered at this point. So what we're approving is the 21-22 Better Care Fund programme. It pains me to say it, but this is where we are. So the budget for the programme was put to this board in June, if you remember, and then the request for the programme came through sort of September time. Then we were approved regionally for our programme in November, and then I have heard that we have been approved finally, and the letter should come through in the next couple of days. So we're in a happy place in terms of national approval for the programme. Couple of things to say. I mean, very much the current programme is a rollover of last year, but with a few small changes which are set out in the paper to sort of reflect changes that have been going on locally. But I think our opportunity really is moving into next year, where nothing has been confirmed about the shape of the Better Care Fund, but an instrument will be there. So we're in a process of learning at the moment through the joint health and wellbeing strategy, and sort of reconfiguring and challenging our ideas about how we do health and care integration and improvement. And that should feed through into the next programme that we develop. Also, we're seeing a change of indicators coming through. So there are two indicators which are carrying on, and where we usually perform very well, actually. One is permanent admissions to residential homes, and the other one is reablement success. But we have new measures in terms of pressures on hospitals and the effectiveness of discharge, of hospital discharge, where we are in a bit of a period of having set some targets based on some near history data, but actually we're in a bit of a period of learning about what those targets mean, what they tell us. And I think there has been quite a lot of criticism of those indicators, which are around the prevalence of conditions which actually probably didn't need to go to hospital, where we score very well, partly because it's so far to go to a hospital, actually, that if people only go when they really need to go. Also looking at the length of stays in hospital, which obviously we want to keep as low as possible for capacity reasons, but also for the speedy recovery of the patient. And then the final indicators are around where people are discharged to, which it's an indicator with some rough edges in terms of, we all know that we want people to be discharged home, but the data is pretty fuzzy at the edges in terms of giving us insight there. So we're changing how we're viewing what good looks like, and we're in a period of learning about that to sort of move forward into whatever next year's programme becomes. So today from you, I'm looking for, basically with the timetable as it was, Councillor Walters approved the programme on your behalf. So I'm looking for a retrospective approval, if you like, but also just any questions that you might have about the programme at this stage.
Thank you, Sandra. Dr. Underwood, and then Dr. Fox.
Thank you, Sandra. At the last meeting I attended with John, I think it was scrutiny, I'm not sure.
Yeah.
You mentioned that getting the staff for domiciliary care is proving very problematical, and this is having a sort of negative feedback on discharging people back to their homes. I just wondered what the situation is like now. Has there been any improvement, deterioration, or is it quite static?
John also might want to, oh yeah, there's a hand. John also might want to comment on this question, but I think actually we are fairly fortunate in Rutland that we have really strong relationships with our providers, both in terms of homes and home care support. We're working with them very constructively. They are quite creative too. And so as we have been experiencing challenges across the COVID period and across the winter, we have so far found solutions to those problems that have kept things moving. But it's about a process of constant alert, communication, creativity to achieve that. But I think we're in a much better position than some parts of the country. John, I don't know if you want to jump in.
Yeah, thank you, Sandra. That's absolutely right, what you just said, indeed. And a partnership, which is something that we always try to do here, is key. We've had our own staff under your guidance, indeed, Sandra, that's been talking to providers, working with providers to the extent of, if necessary, sharing care, changing routes that we can, that people are assured care and assured a rapid and safe, importantly, discharge from hospital. And I'd also like to just say our staff have been absolutely exemplary. They've pulled out all the stops, excuse my French, they're all knackered, and still they keep going, they really do. And as their director, I want to say publicly, I'm so proud of them. And they are working flexibly also. So Councillor Harvey mentioned that we've been unable, and unable is the correct word, to fully open our Brightways at the moment. Well, that's because the staff there are helping out on the front lines to get people out of hospital, to keep our hospitals freed up. And I think it's important that the board recognises that work, and the work indeed that all agencies are pulling together, making these things happen at this difficult time.
Thanks, Dr. Fox.
Just really a point on the people not attending hospitals for ambulatory conditions, and also the low rate of readmissions that we have in Rutland, a lot of which is to credit with the MyCare team, who respond very quickly to need, but also it does have an impact on primary care. And I know that the council is concerned about primary care access. I'll just say that these patients who aren't going to hospitals are coming to primary care, and there is no recognition of the rurality and the impact that has on primary care in terms of primary care commissioning. So when we're looking at primary care access, just to ask you to be aware of the impact of the less available hospital services and the lower rate of readmissions on primary care capacity, which is finite.
Thank you, Dr. Fox.
Very good point.
Do we have any other points from members? No. So, Jane, just oh, there you are. Sorry, Jane, I lost you on the screen then. I was going to say, do we have to take a vote for this one, as we're agreeing formally, we're retrospectively approving? So do we need to actually take a formal vote?
Yes, please.
We do. So I will propose that we approve the funding programme and we note the new targets. Do I have a seconder? Dr. Underwood.
Underwood, thank you.
Are there members of the board, if you could show whether you agree that we do that? Thank you, everyone.
Thank you. That's approved.
That's approved. Thank you very much, Sandra. I think what would be really useful for the board and also probably for the wider public, I know we're in a position where we're not sure around currently how it's looking around the place-based plan and where the funding is specifically sitting, and so there's that little bit of a query moving forward. So I think it would be really useful if we can update the board as and when we hear anything, so that we can kind of all be aware of how things are developing, if that's possible.
Absolutely, yes. Yes, absolutely. There are signs around the edges, if you like, that better care continues. But once I know more, then you will know more. We look forward to it, and hopefully, maybe next time we can do it the other way around.
Let's hope so. But sometimes it is completely out of our control. So, but yeah, if we can be kept aware of how things are going, then people and our residents will realise it's not actually the Health and Wellbeing Board that are delaying it. That actually sometimes it is the fact that we're not made aware beforehand. And I think we're moving on. We've got about 20 minutes left, and so we're moving on to our new Armed Forces legislation now, and we'll welcome Michelle Woolman-Lane to the board, and I think you're going to lead in the absence of Karen on this. Oh, sorry, Michelle, we can't actually hear you.
Am I there now?
You are, that's better.
Technology is proving difficult this afternoon. Good afternoon, Chairman, councillors, board members. Yeah, so I'm stepping in for Karen to share details of the new Armed Forces legislation. Obviously, the paper's been presented. I'm just going to give you an overview. And the ask this afternoon is we're introducing this new legislation, and the ask is that the Health and Wellbeing Board note the implications for our residents, our population, and the work that we need to undertake to meet the requirements of the legislation. So back in 2019, just before the pandemic hit, we actually had a dedicated Health and Wellbeing Board that was dedicated to armed forces, and we presented details of the health needs assessment of our serving community and also the military survey we'd undertaken ourselves. That was in recognition of the significant serving population that we have. And so before I just dip into the legislation, I just want to highlight that Karen's pulled it out in the report. So at least a fifth of our local population have a direct link to the armed forces, and this legislation is about meeting their needs and making sure that they have fair access to public services. So when we talk about the armed forces community and those covered by the new legislation, we are talking about serving armed forces. We have significant population locally. We're talking about reservists. We're talking about veterans. We have the highest percentage population of veterans in the UK as a percentage of population. We're talking about the immediate family members, the spouses, the children, the dependents of all three of those. And then we're talking about bereaved. So there's 5 groups covered under the new legislation. The legislation forms part of the Armed Forces Bill 2000 and the Armed Forces Act 2006, which is renewed every 5 years. So the bill has been going through Parliament for renewal this year. It got approval, royal assent on the 15th of December. And this piece of the legislation is a new clause to that bill. Now, we've been working under the Armed Forces Covenant pledge since 2011. So we're already working in this arena to deliver for this population, but it's now gained royal assent that we have to pay due regard to the legislation. The statutory requirement isn't being stood up until the summer of 2022. That's the language that they're using. So we have 6 months to prepare for implementation. And the new legislation at the moment has specified bodies and functions in scope. The functions are health, housing and education. And then the bodies are with regards to health in particular, local authorities, CCGs, trusts, etc. And I can provide more detail of that. At the moment, under healthcare, they're focusing on provision of services, quality of services, funding, cooperation between health bodies and professionals, and functions concerning additional needs that healthcare bodies have a role in delivering for our armed forces communities. The legislation does not mandate outcomes. So it asks us in our decision making in key areas to show due regard to the principles of the covenant. Those principles being that we recognise the sacrifices that our armed forces community make, and that we recognise the different lived experience that they have that might impact on their ability to access services, for example. So if I just explain a little bit more about the legislation, there is no new burdens funding in support of this. And in terms of the engagement and the understanding that we have of what we need to deliver, statutory guidance is being written. We have been engaging as an authority through the LGA in consultation with them on that for over a year now. We have sight of a second draft of the statutory guidance. That hasn't been finalised as yet. And in our consultations, there have been local authority consultations, which we fed into, and RCC, through that engagement, we have a number of best practice exemplars of the work that we've been doing locally that are going to be included in the statutory guidance. With regards to the wider engagement and for health colleagues, we are told that the MOD Covenant team have been engaging with NHS England at quite a senior level. 7 Brigade, which is the military's community engagement phase, have run consultation activities more locally. We've again attended those, but representation by health colleagues has been limited, I have to say. So the understanding for our wider health colleagues, as opposed to ourselves as a local authority, I think there will be some disparity in the understanding of what the legislation means and perhaps the activity to date. As an authority, we've set up a corporate project to manage the implementation, and John is the chair of the project board for that. And as part of that work, we have reached out, and Karen has written to contacts at LPT, UHL and the PCN to just engage, to say this is how we're handling the new legislation, and can we discuss how we deliver that locally for our residents. I think those are the main points that I wanted to make about what we do know. what has been hugely discussed during the progress of the bill through the House of Lords is the scope of the functions, and there was significant conversation about social care being brought into the wider functionality. At this stage, it hasn't been, but the Secretary of State can add to the functions and the scope of the legislation at any point. The bill will be renewed in 5 years' time. That would be the longest period of time before they might add to the scope. Actually, they might do it sooner. And there was significant conversation about the addition of social care functions, both adult and child, to the function of the scope. But at the moment, it is health, housing, education. In a summary, that's what the legislation is about. John, is there anything else that you think I should add in terms of detail?
No, I don't think so, Michelle. It is what it is. It's giving us now a duty to have this due regard, and that's very important in Rutland. And if I may just take opportunity to make perhaps a recommendation, because you've talked about these functionalities, these three definite ones, and then a possible fourth, all that sit within this this board. You've mentioned and identified that 20% of our population is military. Perhaps we should give thought of inviting the military to have a representative on this board, given what I've just said, given this new these new duties. And I'm looking at Dr. Fox. I know that we've had conversations in the past of involving the military more from a medical perspective around the IDG, and that might, and such a move shows our intention, and also would put a person on this board that we could really start to move things forward. Chair, that of course is over to yourself.
John, I think I agree with your thought process. I do think it would show our commitment to the legislation, and I do think it's important. I'd welcome comments from Dr. Fox and from our other colleagues on the board on their thoughts on the issue. And so I'll bring in Dr. Fox and then Mike first.
Yeah, absolutely. I think if you have the ear of NHS England, I think the primary healthcare for the military population are not part of our primary care network formally. Now, we've informally tried to sort of include them in various things, but the obstacles for their patients for healthcare are often really low level and trivial things, but they are insurmountable. So things like NHS IT systems being mandated for referrals, and they don't have access to NHS IT systems. And so that there are things that you need to understand the detail about in order to make sure that there isn't an inadvertent health inequality. So I'd be really in favour of including them in as part of this board. And I don't think we can get the full picture without doing that.
Thank you, Dr. Fox. Mike, and then Councillor Wellbeing.
Yeah, thank you, Chair. It's a bit of a follow-on from the previous comment, and also a question in my mind. I suppose, I don't quite know what the question is, Michelle. It's almost kind of like the level, it comes back to that system and place conversation around what's the best place of doing this. And I guess the thought in my mind is, you could say, actually, the responsible body for health is LPT for mental health. And they could say they are paying due regard to the concerns of the military, and yet from a Rutland point of view, they might not be doing everything they need to in Rutland. From a provider and a commissioner point of view around substance misuse, we could have the same conversation with public health for Leicester and for Rutland and for Turning Point. And so there is a kind of like, where we talk about functions and bodies, are we clear not so much about the function, but the bodies? And then almost to offer up a kind of what I would want to see is to actually place the Health and Wellbeing Board and the place-based agenda at the heart of being the body that is both accountable for and holds to account others. Otherwise, I fear we'll trip each other up by kind of saying, well, that's absolutely fine at a system level. And yet we're going, yeah, but we know it doesn't work in Rutland. And so I think that, you know, just to add to, it's not just about representation. I think it's about the entire purpose of the Health and Wellbeing Board in respect to this agenda item.
Thanks, Mark. Hold those thoughts on the future of the Health and Wellbeing Board for a second. Councillor Wilby.
Sorry, is that me, Sam?
It is. It is.
Thanks. I couldn't quite detect whether it was myself or Gail who was on. Speaking as a veteran of many years, let me say, whilst the onus is on us to look after our military population, as we are doing, and we do very well, I believe very strongly that the onus is also on the military to actually enjoin us and to make sure that they are sitting in on the various bodies, and so they can, see what is required from them in the community. So I'm very much for this suggestion, and I think they should definitely be someone on here. It's just like we have people on our education performance boards and things like that. The more we bring them into the community, the better, and we make them actually responsible for making sure that the word gets out to their folk on what's required from them.
Thank you, Councillor Wilby. Councillor Waller.
Thank you very much, Chairman. I have looked at this legislation, and it isn't requiring us to do specifics. It's requiring us to have regard. If I may give an analogy, it's very similar in the way it's put together as the disability discrimination and other discrimination legislations are. And I had a lot of sympathy with what Mike was saying, having this morning had the most dreadful trouble with the NHS, and I won't say which bit of it, trying to get a referral sorted because various parts of the NHS refused point blank to communicate with me in an accessible format. So I keep getting pieces of paper and all I can see on it is NHS. And yet I am sure that each part of the NHS thinks they are complying with disability legislation, when quite demonstrably at a practical and a real level, they are not. Having said all of that, what Mike was saying was essentially get them in at the right place. And I think that's what we need to do. I don't know whether this is the right place, because I think this is very much an oversight body, when actually what we're talking about is much more of a detail. So I'm wondering whether the right place is an operational level that feeds into this, if you like. So whilst I have absolute sympathy, as I should, not least because my ward includes one of the barracks in Rutland, and I do have good relationships locally, can I ask that it's thought through so that when they are invited to participate, and I do know that the right participation is invaluable, as I've seen at parish council level within my ward, that we get the right person at the right place, rather than just do there's a piece of legislation, let's do this. And sorry, John Morley, I don't think that was quite how you said it, but I think I'll stop there. I might dig myself a hole otherwise. Thank you, Chairman.
Thanks, Councillor. Michelle, would you like to come back?
Yeah, can I just add, Chair, that we need to remember that we're talking about sort of two populations. So we have our serving footprint, and as Dr. Hillary says, their primary care is managed by Defence Medical Health Services, and then they're accessing our secondary care. So if we're talking about representation and membership, wherever that may sit, there's something about our serving personnel, but there's also then our veteran population, and the families of the serving personnel who choose to use all NHS health services for both primary and secondary. So I do think we're perhaps talking about two elements of representation there from across the community. So there's that engagement with the barracks, and that's potentially with the SMO, the senior medical officer. And we've had some very good traction at different stages. We're gapped at the moment for an SMO locally, but we need to be mindful of the two populations that we're trying to meet the needs of.
Thank you, Michelle. That's really helpful. Viv, do you want to come in?
Thank you, Chair. Yeah, I just wanted to highlight the fact that we're currently doing workshops around developing the priorities for the health and wellbeing strategy, and we've had really good representation actually from our military and veteran population. So one, thank you to Michelle, I know she's been on some as well, and you know, to Sandra for getting the right reps on those meetings. So just to reassure you that, you know, where Councillor Waller was talking about having the right representation for those operational discussions, we have got those people linked in for that in terms of the development of those strategy priorities. But then we will also be thinking around how we do evolve the Health and Wellbeing Board and what subgroups we need to implement the strategy moving forward, in which case we'll be looking again at that wider membership sort of for that. So it was just so that even if there's not membership on the board, that we are starting to look about how we get that membership on the subgroups of the Health and Wellbeing Board. And it also for me links back to something around the communication and engagement strategy, because it might be that we need to think about using that due regard element around how we are trying to communicate and engage with those populations, that we might need to do something slightly different, so we can take some actions away around how we would like to do that. And the other area just to flag is that because the military and veteran personnel are such a key population in Rutland, this is coming out as almost a bit of a cross-cutting theme around the joint health and wellbeing strategy. So I do think there will be much more visibility around this population in the strategy when you see it in its next version coming in February.
Thanks very much, Viv. I think it would be actually useful. I think sometimes leading by example is a good thing, and I think in order to show our veteran population and military population that we're not only nodding to the covenant and the legislation, but actually we want it to be an intrinsic way of working moving forward for our county. I think it might well be something that we should look at having somebody on the board to represent those views, because it does cut across every part of what we offer and what we discuss. And they have a very specific view and lived experience, and that is very different to civilians. And I think that's an important aspect. I'm thinking maybe we could as a board, unfortunately, Sandra, this might well come to you, task you to actually maybe go off and investigate who might sit on the board and who might be best placed, maybe conversations with Michelle over who, between the two of you and between your contacts within our military and veterinary communities, who would be best placed to be the best voice and would be able to advocate throughout for that population as a whole. I don't know whether John's put his hand up, so I don't know whether he agrees and whether he would agree and would look to the board for a recommendation, that as a recommendation. John, I'll let you come in.
Yeah, I do agree, Chair. I mean, with Sandra's new role going forward in supporting this this board, yes, and Sandra and Viv are very intrinsic in driving the strategy. And just to put Michelle in this jigsaw, we're very lucky to have Michelle and the work that she does and her expertise. So if Sandra and Michelle could indeed have these conversations, and also I would strongly recommend, if you are able, if you can identify the right people, to have a chat with those people and see where they think it would best that they sit.
Yeah. So are we happy? Sorry, coming back to Jane for some governance advice. Do we need to take a vote on that, or are you happy for us to just accept that we're going to recommend that? Sorry, you're on mute.
Sorry. I'm happy just for you to recommend it. That's fine.
Okay, that's fantastic. So we'll for this one we're noting the implications for the forthcoming amendment, and we are tasking Sandra, I'm afraid, with going and with the help of Michelle, looking whether being on the board or best place, who the best people would be to ensure the advocacy and voice comes through as an intrinsic part of the board. Thank you. So, Michelle, thank you very much indeed for that and for stepping in at the last minute for us. If you're more than happy to stay for the last 5 minutes, if not, thank you very much. We'll see you soon.
Thank you very much for your time.
To the rest of the board, I know we're running, apologies, we're running a few minutes late. If members do have to go off, we've just got any other urgent business, which I don't think we have any, Jane, do we? No, and then the last bit was the date of our next meeting, which is on the 22nd of February, which will be the place-led plan coming forward, and also the primary care task and finish group initial report on the findings from our resident survey, which I'm pleased to say I think we've had around 1,000 responses, which is a phenomenal response to that. So they're currently just looking at that. So that's really, really good. So they're going to be feeding in. Moving forward on our work plan, which apologies, I'll have to flick. For our February meeting, we have the changes to transport, which hopefully will come through from our primary, from our place-led plan debate on the 22nd, and the final report from the task and finish, primary care task and finish group will be here. And we've also got the place-led plan coming. We have also asked our monitoring officer to look at the terms of reference of the Health and Wellbeing Board. They are somewhat a little bit outdated, and working with partners, we're looking at how the Health and Wellbeing Board and how best we move forward. So we've run out of time today, and I know partners are very, very busy. So if it's okay with everyone, we'll maybe take that discussion offline slightly, and we'll email people around for views on that, on how we take that forward, if everyone's in agreement with that, because I know everyone's busy. If we can have some nods, if someone really isn't in agreement, it's the candor. But if everyone's in agreement, then that we'll take that as read. Thank you very much indeed, everyone. It is 15:59. I will close the meeting with 1 minute to go. Thank you so much for your time, everyone, and we will see you all next month for the place-led plan. Thank you.
Thanks, everyone. Bye-bye.
Thank you.
Thank you all.
Yes, thanks all. Thanks, Chair.
Bye.
Bye-bye.